Thank you, Chita ma'am, for introducing me, even Shimanti. First of all, before starting the session, I would like to thank Cheryl ma'am and Meenakshi Bajaj ma'am, because many of the guidance or guidelines or help I have taken from their chapter which they have published. So you might find many things which are similar or what you wrote actually in a book. So basically, when we are talking about carbohydrate counting and its application in type 1 diabetes mellitus, it is more in pediatric section. It is not that type 1 diabetes mellitus cannot be seen in your adult population, but yes, when we talk about type 1 diabetes mellitus, it is more common in pediatric section of the society. So just rushing up what exactly is diabetes and the different types in just it is like diabetes mellitus is a group of metabolic disease in which there is high blood sugar levels over prolonged period of time. So it is not that in a one night that this child or the patient is being diagnosed as a diabetic. So it is a process with lots and lots of metabolic alteration that is happening in the body and disrupting the biochemical processes in the body, which at one point of time when the body gives up results in something which is called as hyperglycemia or high blood sugar levels. And then when tested, the patient or the person gets diagnosed with diabetes mellitus, that is high sugar levels in the blood. Now moving to the different symptoms of diabetes mellitus, rather than going in details in the depth of the others, sticking to the topic which is basically your type 1 diabetes mellitus, the symptoms which are in blue in color is very much commonly seen in type 1 diabetes mellitus. So when this type 1 diabetes mellitus occur, it is a sudden episode and the child crashes. So when this child crashes, it is there that if you take a recall and when speak to the parents, you will find out, yes, the child was having the history of weight loss, the child was very much lethargic and he was urinating like anything. And he was eating a lot of food. Though eating a lot of food, the child was not at all active. And when the child body gives up, what happens? And the child comes to the emergency and the sugar levels are very high. And when we see this child, there are two common things which are very much common, which indicates that the child has entered into decay. It's the smell of acetone or hyperventilation. So now there are other two types of diabetes, which is gestational diabetes. In the last session, it was a wonderful discussion what we had about gestational diabetes. And then there's another one, which is maturity onset diabetes mellitus among the youngs. And the basic diabetes mellitus, what we studied in our childhood days was type 1 and type 2. When we talk about type 1 diabetes mellitus, it is a condition where the pancreas, they don't produce insulin at all. When they don't produce insulin at all, what happens? The glucose, they don't enter the cells. So this is something really basic and which we all know. Now, when we move to the type 2 diabetes mellitus, it shows that there is insulin, but the glucose is not entering into the cells, maybe because of the insulin resistance or the receptor sides of the cells are not working. So the one major difference is the production of insulin. When insulin is totally not there, we say that the child or the patient is having diabetes mellitus. So when you do the C-peptide test and you look into the range, it gets clear from there that it is type 1 diabetes mellitus. Now, when we talk about type 1 diabetes mellitus, it happens that because insulin is not there, we need to give shots from outside. And these are your mixtures or the lantus, which we give it to the patient or the child just prior to the meals. So there are basically two regime what we follow, that is the basal bolus dose. Basal dose is something which is for the 24 hours, which covers the whole 24 hours, wherein when we talk about bolus, it can be your rapid acting, it can be your short acting, or it can be your intermediate. So the thing is, we need to cover the basal bolus dose throughout the day. Now, when we are giving insulin to the patients, what is our goal? We need to maintain the patient's health. We need to maintain the child's growth. When we talk about child's growth, it reflects your height and weight appropriate to the age of that child, be it a boy or be it a girl. So now moving to the medical nutrition therapy goal for diabetes, the first and the foremost thing, be it type 1 and be it type 2, we need to maintain the blood glucose levels, because Prolonged exposure of the organs to high blood sugar levels will result in the damage. And when the child prolongedly have a very high sugar levels, definitely in a very short run of time or lifespan, the child might enter into other comorbidities along with type 1 diabetes mellitus. The second most important thing is to maintain the lipid profile, or to control the lipid levels of the patient, so that the cardiovascular disease risk can be reduced. And last but not the least, definitely blood pressure, because if the pressure is high, definitely the cardiovascular diseases, the kidney diseases will crop up. Now, to prevent the rate of development of chronic complication, we need to look into the two major aspects in the life of the child. That is, first, the lifestyle. It is nothing like that only the obese or the patient who wants to reduce weight needs to go for some sort of exercise. No, exercises is for everyone, be it thin, be it lean, be it obese or overweight. So this lifestyle modification of, controlling on or modifying the nutrient intake, which is basically your carbohydrate, protein, fats, and planning the diet accordingly so that the maximum macro and micronutrients are balanced in the diet, along with the physical activity and definitely medication, will result in a better health outcome of a child. So now, looking into the target for the known case of diabetes mellitus, sticking to type 1, as per Institute of International Society of Pediatric and Adolescent Diabetes Mellitus 2018, HbA1c should be around less than 7.5%. Pre-meals fasting is 90 to 130, and postprandial it is 90 to 150. That is bedtime or overnight. Now moving to the main topic, that is the carbohydrate counting. Now, when we talk about carbohydrate counting, we all know that carbohydrate is the main constituent of our Indian diet. So you look into the different aspect where we eat from morning till night. We eat a cereal, then we eat, be it in a form of wheat, be it in a form of rice or rice-based, be it in a form of millets. All these cereals and millets, they also contain carbohydrate. Now, looking into the carbohydrate content in the diet, what we actually eat, and the child who is having diabetes mellitus, that to type 1, we need to have a plan on the carbohydrate along with the insulin, which is being prescribed by the diabetes educator or by the treating consultant. So carbohydrate counting is a meal planning approach based on the following idea. First, carbohydrate is a main nutrient which affects the postprandial glycemic response. So it is not only that it is the wheat products, it is the rice products, the millet that affects the blood sugar level. We need to look into the other sources of carbohydrate in our diet, which was already mentioned in the last session by Lata ma'am, that it is dal and dal products also which contains carbohydrate, milk and milk products which contains carbohydrate, and then again fruits. So when we talk about carbohydrate, it's not about restricting on the cereals and millets. It's like planning a diet with cereals, pulses, milk, and food, so that the blood glucose remains controlled and the sugars doesn't rises for the child. Total amount of carbohydrate is most important than the source of carbohydrate. Now, this is very much common when we come across, when we take a diet recall for a patient. This is something which we all have faced. The patient, the person, the moment gets diagnosed with diabetes mellitus, the first and the foremost thing what they do is like, I am not taking rice at all, and I'm emphasizing more on chapatis. So they don't understand that yes, there can be a difference between a glycemic load, there can be a difference in the glycemic index, but you have to look into the quantity of chapati what you are taking when you are avoiding rice. If you are avoiding rice but you have not curtailed on the quantity of chapati, it again reflects that your blood sugar will definitely be on a higher side. Reasons behind popularity: it is effective, it is flexible, and it is easy to implement. So once you teach the parents, once you teach the child who is adult, then definitely the child or the parent become very much confident, and it becomes easier for them to have a normal balanced diet what actually is cooked at home. So it is nothing like for the parents that because the child has been diagnosed with type 1 diabetes mellitus, they have to cook food separately. So now moving to the calculation. So when we talk about the calculation, the first and the foremost thing what we need to come across on basis of which we need to distribute the carbohydrate is the calories. And because this child is in a growing phase, we can't cut down on the protein requirement of the child. So for that, specifically, we need to look into the protein requirement of the child based on the weight of a child, and then the calories per kg per day. Say, for example, if the child is 6 years old and the weight of the child has to be roughly around, as per IPA guidelines, 20 kgs. So 85 into 20 kgs will give us the calories per kg per day for the diet for the child. When simultaneously, if we multiply the weight with the protein as per the guidelines, it will give us the protein requirement of that child for the day. Now, the simple and the most common, form of, calculating is like, for the first year of life, it is 1000 kg. For the after 1 year of life, for the boys, it is age multiplied by 125 plus 1000 kg, and for females, it is 100 instead of 125 kilocalories. So now when we know about the calories, we know about the proteins. Now we come to the calculation of a carbohydrate. So it is around 50 to 55% of the total calories. So the calculation was very simple. It is for, if the prescription is for 1400 kilocalories, divided, that is 55% of 1400 will give us 770 kilocalories, which in turn will give us 192 grams of carbohydrate, that is equal to your 12.8 exchanges of carbohydrate. Now, this carbohydrate is actually the carbohydrate from the cereals, from the millets, from the fruits, from the pulses, dal and dal products, and even with the milk. And we cut down on further, that is 50% of the calorie, 50% of the total calories. The exchanges is around 11.6 with 175 grams of carbohydrates. And fat should not be more than 35% of the total calories. Now, if we look into this slide, this is a very self-explanatory slide, which doesn't require any explanation much. When you take fruits, within half an hour, the blood sugar level peaks up. With the starches, it is 2.5 hours. There is a rise in the blood sugar level. And when we give more of fiber in the diet, it extends up to 2.5 hours of your ingestion of carbohydrate. Now, when we talk about carbohydrate choices, this I have already mentioned, which are the sources of, foods that contains carbohydrate. Now, looking into the one carbohydrate choices. So it is always good to make the parents understand about the importance of standardization. Initially, they find it very difficult that how they are going to cook a food with, 30 grams of raw weight, 45 grams of raw weight, or 60 grams of raw weight. What I usually explain is, when you follow or prepare a very simple recipe of a very good chef, if you look into the ingredients, what they mention, and they look into the serving size, you can definitely understand how much important the ingredients hold to have a very tasty recipe, what a chef has given. Similarly, for a child to have control on the blood sugar level, the quantity of food, what the child is eating is utmost important. So when you standardize the food item, what the child is taking, or your meals, what you are preparing at home, it becomes easier for you and for the child to have a healthy, balanced diet. Now, that doesn't mean that the mother every day needs to cook the food on daily basis as prescribed by the dietitian. I give mothers 1 week time, that these are the prescription, these are the mentioned amounts what the child needs to take. Now, how will I know what is the life pattern of the child? First of all, I take a recall. So a recall is utmost important to find out the habits of the child. What are the eating patterns of the child? What time child gets up? What time the child takes his breakfast? What time is the tiffin time? Because this child, after being diagnosed with type 1 diabetes mellitus, will not sit back at home. He has to retain his normal activity. And normal activity means his physical activity, his gaming, his schooling, his extracurricular activities. So that pattern needs to be taken up, and then planning a diet based on that pattern. Usually I feel you should not change the dietary pattern drastically for a child in the initial days, because first of all, it's a very new thing for a child to get diagnosed with something which is weird, where he is being pricked even for testing and even for ingestion of insulin. So this has a definitely a psychological impact on the child. And even parents are scared that how are they going to manage that. So it is always good to plan a diet which fits their regime, which fits their lifestyle. So if the child takes a glass of milk at 6:30, it's good to have a milk at 6:30 in the diet chart also. Now, say for example, the child takes rice in the breakfast. It's good, the child will take rice in the breakfast, but the quantity, say for example, 30 grams is being mentioned as per the diet plan of the child based on the insulin which is being prescribed by the doctors or the diabetes educator. So the mother has to take to a tedious job in 1 week. Whatever is the meals needs to be standardized. So this 30 grams of raw rice needs to be cooked, and it needs to be given in the katori or the bowl what is there present in her home. Now that katori or bowl becomes the standard. So when the rice is cooked for the whole family, she knows how much rice from that bowl needs to be given to the child. So how much ever 50 grams, 15 grams of carbohydrate is mentioned over here. For the packet food, it is okay. But for the raw weight, it is always good to standardize a diet as per the meals what is being prepared in the family, because meal pattern of one family to other family definitely varies. Now looking into the fiber content. Fiber is utmost important, because when we take a recall and we find that the child was eating voraciously, but we can't give extra carbohydrate, we have to curtail on the carbohydrate, keeping all the four food groups that are a good source of carbohydrate. So when we plan that, we need to give extra food which are termed as free foods, so that the child gets satiety. So there are different guidelines. So as per 2012 AP guidelines, the fiber recommendation is age sorry, age plus 5 grams per day, which is again can be sum up to 0.5 grams per kg per day and can go up to 35 grams. As per Institute of Medicine, it is 14 grams per 1,000 calories, and FDA labels is as 12 grams per 1,000 kilocalories. Now, for the first time, the WHO has given in 2023 the guidelines for pediatrics fiber recommendations. So for age specification, for to get 15 grams of carbohydrate, it is said that 250 grams of vegetables and fruits needs to be included in the diet. Moving for 21 grams, which stands for around 6 to 9 years of age, it is 350 grams of vegetables and fruits. And more than 10 years, it is 400 grams, which will give around 25 grams of fiber. Now, I will take another 5 minutes. I'll be over by that. So coming to the carbohydrate choices from food levels. So this is something which is important that needs to be taught to the parents also. So what happens, I ask the parents to get the food product or biscuit or, Maggie. From there, it is easier for them to make them understand how much that the gram of Maggie is and what is the serving size carbohydrate which is given in that serving size of that packet food. So say for example, if the serving size over here is 3 pieces, so one piece is around 30 grams and it contains around 30 grams of carbohydrate. So when we talk about 3 pieces which contains 30 grams of carbohydrate, we need to deduct fiber which is again mentioned in it, that is 3 grams. So that will give us the amount of carbohydrate which is present in that packet food and how much in that specific meal, say in a snack or maybe in a midday meal, that can be given to the child if the child demands. So now looking into the carbohydrate distribution across meals. So whatever the guidelines and the standard says, it depends on the type of insulin, midday meal and bedtime snack needs to be distributed. But again, I usually take a recall, and accordingly, if it is required, then only I incorporate bedtime snack. Mid-meal snack is definitely there, but bedtime snack is something if the child takes, then definitely I incorporate that in the diet, irrespective on the type of insulin, because as I mentioned already, the child is in dilemma with so many changes in the body. So at initial point of time, we don't want to hustle the child with it. But again, quantity, if can be curtailed, will help the child to overcome. Now coming to the insulin and carbohydrate ratio factor, which is utmost important, we have rule of 450 and we have rule of 500. So that 450 divided by the total daily dose which is being prescribed will give us the amount of carbohydrate that 1 unit of insulin will metabolize. Insulin sensitivity factor or the correction factor, it is the rule of 1700, which is divided by the total daily dose, will actually give us that how much mgdl glucose will come down with 1 unit of insulin. So if you look into the example, 1700 divided by 335, which is again the total daily dose, which will come as around 48 mg. So roughly around 50 mg per dl with 1 unit of insulin will drop the blood glucose level. So now again, hypoglycemia is utmost important. We need to even educate the parents about it, that how you have to curtail or give carbohydrate when the child suffers from hypoglycemia. So as the guidelines says that it is definition, sorry, it is less than 70 mg per dl. We need to give 15 grams of carbohydrate. When we give 15 grams of carbohydrate, after 15 minutes, we need to recheck. And then if it is okay, then the meal has to be around, say, with a protein and a carbohydrate combination, so that the sugar level sustains. So these are the different sources of carbohydrate, which reflects with the grams or sorry, it's the amount of carbohydrate.
Komal, I think we have to wrap up, Komal.
Yes, ma'am. Yes, ma'am. So now moving into the patient education, which is my last slide. A diet that includes carbohydrate from fruits, vegetables, whole grains, legumes, and low-fat milk needs to be encouraged. People with diabetes are asked to avoid sweetened beverages. The quality and quantity of dietary fat both are utmost important, which needs to be counseled and explained to the parents. Fiber and protein cannot be overruled. Protein we don't restrict until or unless we see any organ it's compromised. Otherwise, we need to look into the growth charts and give the protein as per the prescription for the day. Thank you so much.